Hello, I'm Dr. Thomas Clark, and welcome to a webinar on the overview of weight loss surgery. I'd like to thank you as well for taking time to tune in. We're going to cover pretty much all the aspects of weight loss surgery. I would encourage you to plan on spending about an hour. If you have to come back to it, fine. But this overview is going to take about an hour or so. If you have questions, I encourage you to write them down. And then once we're done is pick up the phone or send us an email and set up that one-on-one appointment so that we can go over your situation, because everybody's situation is different. And then we can also get you plugged in and get you working on kind of getting those insurance approval, because insurance approval can sometimes be the harder part of this whole thing really, as well as, or if you're thinking of doing self-pay, which we see lots of patients doing that as well, we can get you plugged into the system, get you started right away. So again, welcome, thank you, let's get started. All right, we're coming to the center here. We're located at 645 J. Clyde Morris Boulevard, Newport News. The phone number as well, 757-873-1880. But we do cover the whole aspect of weight loss. We have a full fitness center, nutritional store, educational classroom. The only thing we don't do at the center is the actual surgery. So the surgery, yes, we do it at the hospital. Generally, it's an outpatient, but still everything else is covered kind of there at the center itself. Again, J. Clyde Morris, Newport News, Virginia. All right, we do have an educational classroom. I throw this slide up here because education is huge. It is an extremely important part of this whole thing. The surgery itself literally is an important piece, but it's getting the most out of the surgery. So the education and support side, very important. We have a full year program after the surgery to really educate you and then also work on implementing all the things that you learn in order to get the most out of this. You want to optimize weight loss and then keep that weight off long term. Now, we do the educational classroom. We do a lot of the classes right there in there, but with technology, just as you're doing now, you can get this recorded. We have a membership site as well as we record webinars all the time. I do live webinars every single week, which gives you access to me to ask questions. But the educational side of this, the support side of this is extremely important. And I do encourage people to keep that in mind. The surgery is just a piece of this. And with that educational side and all the support side, we see better weight loss, which we'll get into more in a little bit here. We also have a nutritional store on site. It's open to anybody, so it's not only for our patients. Literally anybody can walk in there. Having said that, everything in there is directed towards weight loss and health. But there's also nothing magic in there either. You still have to do all the right things, and the education and support side, very important. So, but anybody can come in and look around. I encourage you, if you just want to stop by, look around the store, the girls there, they'd love to kind of show you around and kind of all the different things they do. And if you want to, you can get involved as easily as doing that. A little bit about myself. Yes, I do surgery. I'm a board certified American Board of Surgery, but also board certified the American Board of Obesity Medicine. So we actually do medical weight loss as well. So I'm board certified in two separate specialties. They are two separate specialties. I've performed over 5,000 weight loss surgery procedures over the last 25 years. And with that, I'll also admit that I have some leanings, if you want to call it that, to what tends to work better for most people. We'll get into that here in just a few minutes as well. But this is all I do. I don't do other things. I only do weight loss. All right, well, let's get started. So what are we going to talk about? Obviously, we're going to talk about the problem of obesity, but then also what can we do about it? What can we do about the excess weight? What are the operative procedures? And we'll cover gastric bypass, adjustable bands, sleeve gastrectomy. And we'll talk about the risks of having surgery as well as the results of the different procedures. Now, I'll give you kind of my opinion before we get started here. For most people, I think the sleeve gastrectomy is probably a better option. And we'll get into the reasons of why, but I've been doing this long enough, good 25 years. I see all the problems that can arise from nutritional problems, abnormal anatomy problems with bypasses, as well as device problems with adjustable bands, with relatively poor weight loss with adjustable bands, with sleeve gastrectomy, fairly low risk procedure, pretty quick recovery. We see really good weight loss with it, which is obviously the whole point. And you also keep your anatomy normal. And I've become convinced over the years of doing all these different operations that keeping anatomy normal is probably a good thing. So let's go and get into the details here. So just as an introduction to, weight loss is hard. Okay, surgery really just should be thought of as an extension of medical weight loss. Okay, it's not like there's something magic about having surgery. It's not like you have surgery and weight just magically falls off. It's like, no, it's still diet, exercise, activity, behavior modification that gets you to lose weight. So surgery really is just a tool. So you hear us say this all the time, that surgery is a tool. It's a tool to assist you with weight loss. Nothing magic, but that's all it is. And a tool can be either used correctly or it can be used incorrectly. Used correctly can be extremely powerful. Used incorrectly doesn't tend to work that well as you can get into some real problems with it too. But really, surgery is just a tool. And so subsequently, you have to do the right things. Long-term, weight control is still hard. Sometimes people think that, okay, I have this operation and I lose all this weight, great, and now I don't have to worry about it anymore. But, well, yes, you do, because you can regain your weight. It doesn't matter what operation we're talking about. You can regain your weight. Long-term, weight control is still really hard. You need to do the right things. And part of doing the right things is you have to know what are the right things to do. And then how do you implement those right things? Because sometimes the concepts are very straightforward. You still got to know what they are. But then implementing those concepts, that's the hard thing. And that's where kind of the expertise here, the supports here, the kind of how do you get these things done? How do you do this in your life? Because life tends to get in the way all the time and trip us up. And what we find is that the surgery itself, combined with medical weight loss program, gives you the best chance for long-term success. And it's not that we're doing different operations, better operations. No, we're doing the same operations that most every place is doing, but we see better weight loss. I'll say that again. We see better weight loss. And that's the whole point. And we see better weight loss because it's the education and support side of this whole thing that really gets people optimizing weight loss and then keeping that weight off long term. And that is absolutely key. All right, now lots of different medical problems go along with weight. So what I've listed on this slide are really common medical problems. Every single one of them is directly related to weight, meaning as weight goes up, they get worse. As weight comes down, they get better. Some of them completely go away with weight loss. If they don't go away, they at least get a lot easier to control, but they're all really common. And some of them are really significant. Diabetes, high blood pressure, kind of these heart disease. These things can potentially be life-threatening. So they're really important to treat, and weight loss treats them all. Now, if I could boil it down to what's the biggest problem, when you take all these things together, is that risk of dying goes way up. For someone that's 75 to 100 pounds overweight, on average, you're going to die about 10 to 15 years before someone who's not. That's what we're talking about. That's the issue right there. We want you to live a long, healthy life, die of old age. Okay? So, last thing we want is that premature death. So subsequently, treating obesity, treating the weight problems, we will, by treating the weight, we then subsequently treat all these other problems. Now, how do you measure it? Obviously, if you walk in your bathroom, you step on your scale, you kind of look down and go, yeah, I know it when I see it. But actually, just a weight number doesn't really help very much from a clinical perspective. So you often see this body mass index term thrown around, or BMI. Body mass index just takes your height into consideration, height and weight. Because if you think about it, height matters when we start talking about how overweight someone is. As an example, say you have two people that are both 100 pounds overweight. One's 6'6", the other one's 5 feet tall. Well, the one who's 5 feet tall actually has a much higher health risk with that extra weight than the one who's 6'6". And that shows up then as a larger body mass index for the shorter person. So body mass index just takes your height into consideration, but it's a way to stratify health risk. The higher someone's body mass index number, the higher their health risk. And most insurance companies will have certain kind of levels. Okay, this is kind of the point that actually tells, are you a candidate or not? We're going to talk about that a little more in a minute. Now, another thing to keep in mind during weight loss, especially during weight loss, is body composition. Now, body composition is basically looking at what is your body made of. Okay, how much is fatty tissue versus everything else. The fatty tissue, that's the unhealthy stuff. That's what you want to get rid of. The everything else we refer to as lean body mass. Lean body mass technically means everything that's not fat. But the lean body mass is the healthy tissue. It's what you want to keep. It's what drives your overall metabolism. The more lean body mass you have, the higher your metabolism. Okay? So it's really important to keep an eye on body composition during weight loss. Make sure you're losing the fatty tissue, not losing the lean body mass. Now, people have often proven that concept to themselves throughout their lifetime without realizing it. And what I mean by that is that if you've gone on a aggressive weight loss plan, lost a bunch of weight, great. Go off that weight loss plan and find, hey, it's even easier to regain weight, and weight goes even higher. You know, why does that happen? Okay, well, when you went on the aggressive weight loss plan, if you lost a bunch of lean body mass, you slowed your metabolism down. So you slow your metabolism down, now it's even easier to regain weight. Weight goes up even higher. And if you do that multiple times throughout your lifetime, it keeps getting harder and harder to lose weight, easier and easier to gain weight. So really important concept during weight loss is keeping an eye on body composition. And it doesn't matter whether we're talking about surgery weight loss, medical weight loss, just weight loss in general. Keeping an eye on body composition, you want to preserve that lean body mass, get rid of the fatty tissue. All right, so who then is a candidate for surgery? Now, every insurance company has their own set of criteria. They almost all follow National Institutes of Health recommendations. The National Institutes of Health, the government agency, got together now it was 1991, so over 26, 27, 28 years ago, whatever that was, 28 years ago, and put together this list of criteria that if you meet these criteria, you're a candidate to consider surgery. Okay. So most insurance companies follow that. Now, they've never been updated. They were put together in 1991. They've never been updated. They need to be updated, but that's neither here nor there at this point. Most insurance companies follow National Institutes of Health recommendations. So what do they say? Anyone that has a body mass index over 40 is a candidate to consider surgery. Now, body mass index of 40 is around 100 pounds overweight. You may be completely healthy otherwise, no health problems at all, but if you have a body mass index of 40 or more, generally around 100 pounds overweight, you're a candidate for surgery. And if you have a body mass index of 35 or more with medical problems, now when I say with medical problems, then body mass index of 35 is around 70 pounds overweight. So body mass index of 35 with medical problems. Which ones matter? Okay, every insurance company has their own set, but they almost all include these three: diabetes, high blood pressure, and sleep apnea. Then they may or may not throw other ones in there: cholesterol problems, arthritis, back pain, fertility, whatever. But they almost all include diabetes, high blood pressure, sleep apnea. And it doesn't matter whether you have one of those or if you have all of them. Okay? So body mass index of 35 or more with medical problems, or body mass index of 40 or more with or without medical problems. Now, from my perspective, anyone who's significantly overweight and has health and lifestyle problems related to their weight and have tried pretty much all the other medical problems and just not getting success, then they're potentially a candidate to consider surgery. And it's just, I have a slightly different perspective on this than most of the insurance companies do. And that's just a slightly different perspective then. All right, so what are the options then? So I've listed on this slide are the most common options done worldwide. They're also the ones done in the United States, or the ones we do around here. Gastric bypass, laparoscopic adjustable gastric banding, or sleeve gastrectomy. Okay, well, we're going to go into detail on all of these, but gastric bypass has been around for a long period of time. It's been around, the first gastric bypass was done in 1955, so it's been around for over 60 years. Okay? So it's a well-studied operation. We know what happens to people when they have gastric bypasses. We know the problems that can arise. We know what to do about those problems. So it's a very well-studied operation. Adjustable gastric bands. Okay? They've been around in the U.S. since 2001. Worldwide, they've been around since the early 1990s. Okay? So, kind of, why do I care how long an operation's been around? Because when we start talking about long-term problems, long-term results, by medical definition, long-term means 10 years or longer. And that wouldn't matter whether I was talking about brain surgery, heart surgery, knee surgery, doesn't matter. Belly surgery. Kind of 10 years or longer, that's kind of long-term results type of thing. Okay, but with some of these operations then with weight losses, we're going to be talking about things that literally can maybe 20, 30, 40 years. And if you're fairly young, potentially 50, 60 years out there. So kind of looking at these long-term issues are very important and kind of how it's going to impact your health over your lifetime. Right. Sleeve gastrectomy, a little newer kid on the block, but it's actually not a new operation to use for an old operation. We used to do sleeve gastrectomies for different reasons, not weight loss. But about 15 years ago, there was a hormone discovered called ghrelin. And ghrelin is a hormone made by part of your stomach that makes you feel hungry. And so we found, hey, if we took that part of the stomach out, we've actually done two things. One is we made you a much smaller stomach, so you can't eat very much. The second thing, though, is when we take that part of the stomach out, that makes that hormone ghrelin levels then go way down. And since ghrelin makes you feel hungry, when ghrelin levels go way down, hunger is much easier to control. And if you think about it, one of the potential downfalls of every single weight loss plan in the world is hunger. If we can control hunger, a lot easier to lose weight, a lot easier to keep that weight off. So sleeve gastrectomy is actually the fastest growing option out there. It is the most common operation done for weight loss nowadays. Last year, somewhere around 2/3 of all operations done for weight loss were sleeve gastrectomies in the U.S. It's close to 95% of what I do nowadays because it works so well and we see pretty quick recovery with pretty low risk. It keeps your anatomy normal. All right, we're going to go into the details then about these because the more you know about the different operations, the better off you're going to be. All right, talk about gastric bypass first because it's been around for the longest period of time. If you've known anyone that's had a gastric bypass, they lose weight fairly quickly. Now, a little comment about speed of weight loss. People are often very concerned about speed of weight loss. Speed of weight loss doesn't matter. What matters is what are you losing? It goes back to that body composition discussion. If you're losing weight really quickly and losing all fatty tissue, it's like, great, the faster the better. On the other hand, though, if you're losing weight pretty quick, but losing a lot of that lean body mass, that's not so great because you're going to get tighter and tighter, weaker and weaker, and slow your metabolism down further and further, which is going to make it harder and harder to lose weight and easier to gain weight. So speed of weight loss by itself doesn't really matter. What matters is what are you losing. But no matter what, if you have gastric bypass, you're going to lose weight pretty darn fast. Now we refer to gastric bypass as being restrictive and malabsorptive. What does that mean? Well, restrictive means we're making you a smaller stomach. And if we make you a smaller stomach, you can't eat very much. You're going to lose weight. So the concept's very simple there. We make you a smaller stomach, you're going to lose weight. You can't eat very much, you're going to lose weight. Now, with the gastric bypass, we literally make your stomach probably about the size of an egg. An egg, so tiny. Now, I'm going to digress here for a minute because everybody thinks of this question very shortly in that, okay, you made your stomach the size of an egg. Now, is your stomach going to stretch out? And the answer is yes. We know it's going to stretch out. And actually, we want it to stretch out. So we don't want your stomach the size of an egg. What we're shooting for long term with all these operations, gastric bypass, adjustable band, sleeve gastrectomy, what we're shooting for long term is meal-sized small plate. That's where we want to go. But we're working with stretching material. Your stomach is stretchy, just like your skin is stretchy. Okay? Your stomach is stretchy. If we made your stomach meal-sized small plate to start with, it would stretch way out. A normal-sized stomach can hold about 2 to 3 liters. You think of those 2-liter drinks you get at the grocery store. Normal-sized stomach, that's a small normal-sized stomach. So we have to make your stomach tiny to begin with, knowing that it's going to stretch out. Again, what we're shooting for long-term, that's true with all these operations, meal-sized small plate. That's where we want to go. All right, so anyway, make this tiny little stomach, therefore it's restrictive, you can't eat very much. Now the second part is the malabsorptive part. That's where the bypass comes in. I'll use my little pointer here, see if I can point out that we're going to bypass the rest of this stomach right here, called the excluded portion of the stomach. We're going to bypass that. And the way we do it is, well, we go a short distance downstream on the very beginning of the small intestine. We divide the beginning of that small intestine, and we pull that new end up, and we hook it into that tiny little stomach so that we've bypassed the rest of the stomach in a short portion of the small intestine. And whenever we bypass any of the intestinal tract, you're not going to absorb things perfectly. So you don't absorb all the calories that you've eaten, which is part of the way the operation works. But you also don't absorb some of the vitamins, minerals, micronutrients quite as well either, which can be problematic long term, which we'll talk a little bit more about. We talk about risk here in a minute. All right, surgery itself doesn't take that long, about an hour and 40 minutes. Most surgeries nowadays can be done, laparoscopically or minimally invasive. What we do is we use long instruments and TV cameras, little incisions on you. And subsequently then recovery is pretty quick, or hospital stays pretty quick, but actually full recovery can take a while because this is a big operation. Whenever we start rearranging your anatomy, that's a big operation. And so subsequent recovery can take a while, good 4 to 6 weeks, even sometimes up to 8 weeks to really feel like I'm back to normal. Now, there's risk with every single operation in the world. Gastric bypass, no different. And since this is a bigger operation, typically the risks are a little bit bigger. Now, when I talk about risk, I divide it into 2 time frames. And this is a medical standard. It's not something I made up. This is a medical standard, which basically is right around surgery, which by medical definition means first 30 days. The second time frame is long-term, which by medical definition means longer than 30 days. Okay? So, first 30 days, then long-term, which is longer than 30 days. All right? Well, what's the worst thing you could ever hop in that first 30 days is, could you die? And the answer really is, yeah, it could happen. The risk of death is real when we start dividing your intestinal tract. And it wouldn't matter whether I was talking about taking your appendix out or taking part of your colon out for some reason. Whenever we as surgeons start dividing the intestinal tract, the risk of death is real. When you look at national statistics, it's actually about 1 in 200. What we see is about 1 in 500. So the bottom line, it may be rare, not impossible. Obviously, that's worst case scenario right there. Other things we watch for, probably the things we worry about the most are infections. Some infections relatively easy to treat, things like urinary tract infection after any type of surgery. A couple days of antibiotics, they go away. Other infections aren't so quite easy to treat. Things like pneumonias. Pneumonias can actually occur about 2% of the time after any type of surgery where you'd have to go to sleep for it. You do have to go to sleep for all these surgeries. And it's somewhat related to how long did the surgery take. So pneumonias can actually occur about 1% of the time, 1 to 2% of the time after any type of surgery that you have to go to sleep for. Well, the biggest fear as far as infections go, what if you got a leak on the inside? Basically, where we did your surgery, where we took the pieces apart, where we put them back together, what if it leaked? Well, that's a rip-roaring infection. And there are literally trillions of bacteria that live in your intestinal tract. When we start dividing the intestinal tract, some of those bacteria potentially can get out. They set up shop. If they set up a rip-roaring infection there, potentially you'd have to have a second operation to fix that. Okay? Wound infection means on the skin. Any place we made a little incision, could you get a little skin infection? Those are, I'm going to call them more nuisance problems and dangerous. They still have to be treated. Typically put you on some antibiotic. They go away pretty quick. DVT or PE, what does that mean? DVT means deep venous thrombosis. PE is pulmonary embolus. We're talking about their blood clots. Now you can get a blood clot without having surgery. You can get a blood clot from getting dehydrated, or if you take a long airplane ride. That's one of the most common reasons to get a blood clot, long airplane ride. But you can also get a blood clot from having a general anesthetic. Again, you have to go to sleep for these surgeries, and it's somewhat related to how long did the surgery take. The longer the surgery takes, the higher the risk is. We do all kinds of things to prevent that during surgery, but still, anytime with a general anesthetic, having a longer surgery, it can happen. Again, gastric bypasses take about an hour and 40 minutes, therefore the risk is somewhere in that 1 to 2%. If you got a blood clot, you'd have to be on a blood thinner to dissolve that blood clot. Nausea, vomiting, dehydration, kind of sounds obvious, but here's what happened. We make you this tiny little stomach. The first thing that happens to the tissue of that tiny little stomach is the tissue swells up. Just like if you walked outside and tripped over, you sprained your ankle's going to swell up. Well, whatever tissue we operated on, it's going to swell. So we make you this tiny little stomach, the tissue swells up, so stuff just trickles through there initially. And if you're not able to stay hydrated, you may have to come back to the hospital, get some IV fluids, let that rest for a couple days, let the swelling go down. Now, long term. Long term again means 30 days out to forever. Okay? The most common physical problem, long term, after a gastric bypass is getting an ulcer. Now, you can get an ulcer without having a gastric bypass, but when you have the anatomy of a gastric bypass, the risk of getting an ulcer goes up. Who tends to get ulcers? Smokers and people that take a lot of anti-inflammatory medications. Now, ulcers typically don't need more surgery. They just need to be treated. Lots of good medical treatment for ulcers nowadays. Something that might require more operation, or another operation, is a bowel obstruction. Are you familiar with the term adhesions? Adhesion just means scar tissue. And if you've had any surgery on your belly, you're going to have scar tissue, not only on the skin, little incisions, but actually on the inside. And that scar tissue potentially can kink the intestine. And just like a kink in a hose, nothing's going to go through there efficiently. We may have to take you back to the operating room and unkink that. Hernias, now you can get hernias without having surgery. Belly button hernias, groin hernias, they're pretty common. But any place we make an incision is potentially now a weaker spot. Stenosis means narrowing. And we're talking about, and sometimes called stricture. And what we're talking about is right where we take that little tiny stomach and hook the small intestine up to it, right where we put those two things together. Could it actually scar down and get too narrow? If it did, we'd have you see one of the well, if it did, stuff wouldn't go through there very well. Food, liquids, that. So we'd have you see one of the gastroenterologists. They can actually take a look down there. They use a balloon that can actually stretch that out. So it typically doesn't need more surgery, but it does need something to evaluate it and treat it. Right, vitamin nutrient malnutrition. Now this is something I alluded to earlier, and this is relatively common. Okay? You're not going to absorb things perfectly. You don't absorb all the calories, okay? But you're not going to absorb iron as well, B vitamins as well, calcium as well, magnesium as well, vitamin D as well, certain protein as well. There are a number of things you don't absorb as well. And because of that, you may have to be on extra things long term, as well as you're going to need a battery of lab tests checked every 6 months to a year to make sure those things are staying where they should. That's a forever thing. That doesn't go away. All right, well, what are the results of gastric bypasses? Obviously, the whole reason for doing the surgery, we see really good results with gastric bypasses. On average, you'll lose about 70% of what you were overweight. So if you were if you were 100 pounds overweight, losing 70% is losing 70 pounds. If you're 200 pounds overweight, losing 7% is about 140 pounds. That's average. Some people lose more, some people lose less. Okay? Long term, and this is where I have a problem with gastric bypass, about 40% of people with gastric bypass regain almost all their weight back, which is kind of a real problem. We see really good weight loss with it, but we see significant weight regain as well. So overall, this is my take on gastric bypasses. The long-term anatomical and nutritional problems with relatively poor weight maintenance, good weight loss, but relatively poor weight maintenance, makes it difficult for me to recommend gastric bypass for most people. All right, shifting gears, adjustable gastric bands. This is the second operation. Been around the U.S. since 2001. We often refer to it as kind of the least invasive surgical approach to weight loss because we're not dividing anything, we're not stapling anything, we're placing a band around the very top of the stomach. Okay? So then it's the lowest risk, right? No stapling, no cutting, no intestinal rerouting. All we're doing is placing this band around the very top of the stomach. It makes you this little tiny stomach, so you eat a little bit of food, you get full. But all the food still then travels down the rest of the stomach and through the intestinal tract normally. So everything is digested normally. Nothing is bypassed. Your anatomy stays completely normal. Okay? So no stapling, no cutting, no intestinal rerouting. It is adjustable. We can tighten it. And it also is reversible. So reversible, if for some reason you need to get you back to normal, we'd have to take you back to the operating room, basically cut the band, unlock the band, slide it out, you're back to normal anatomy. Still, it's the scar tissue and surgery up there, but you're back to normal anatomy. It's also adjustable. So to tell people, the good news with adjustable gastric bands is it's adjustable. The bad news is it's adjustable. And what I mean by that is it doesn't work worth beans if you don't get it adjusted. And you need to get it adjusted throughout your lifetime. Most people need about 4 to 6 adjustments during the first year. Second year, it's usually about 2. After that, it's about once a year. Now, people often wonder why. Why do I have to keep getting this thing adjusted? Why couldn't we at the time of surgery? Go in there, kind of set this band the way we wanted it, kind of adjust it at the time of surgery, set it the way we want it, and walk away and just be done with it. Here's the reason. All these, if you see models of this operation or pictures of this operation, are oversimplified. There's actually a tremendous amount of fatty tissue that's draped over the top of the stomach there. And this band is fairly large. It has to go around a lot of that fatty tissue. And as you lose weight then, the fatty tissue is going to melt away. So as you lose weight, the band's going to be looser. So just like as your pants get looser as you lose weight, similar thing. You're going to lose weight where the band is, and subsequently the band will be looser. So we need to be able to tighten it down over time. Most people, again, will need 4 to 6 adjustments during that first year. Now, long term, people often wonder, why would I ever have to get adjusted once I've lost the weight? 2 reasons. The first is it's a mechanical device, and we need to check on it. Make sure it's functioning appropriately, there isn't any changes or any abnormalities with it. Second thing is, like most pressurized systems, it doesn't hold pressure perfectly. So usually about once a year it needs to get checked, but then usually it needs to get tweaked. Okay? When I say it doesn't hold pressure perfectly, it's kind of a similar thing as, if you put your bicycle away for the winter and you pull it out in the spring, you usually have to put some air in the tires. That doesn't necessarily mean there's a leak in the tire, it just doesn't hold pressure perfectly. Similar thing here, it doesn't hold pressure perfectly. We generally need to check it as well as to tweak it. And that's a forever thing. It doesn't go away. Now, the actual surgery with that, a very low malnutrition risk because your anatomy is completely normal. You absorb things normally, digest normally. Surgery itself doesn't take that long, generally 35, 40 minutes. Generally does an outpatient. So you come in, have the surgery done, and recover at the hospital and go home. But it's a really short recovery. Most people are feeling pretty darn good by about 2 weeks. Within a few days, feeling pretty good. 2 weeks, you can pretty much do anything you want to. So recovery is pretty quick. Now, so what are the risks of doing this operation? Okay, again, we'll look at kind of around surgery, first 30 days, and long term, longer than 30 days. Now, you'll notice if you look at this left-hand column here, the right around surgery, first 30 days, that basically the list is the same as a previous operation, as gastric bypass, which will also be the same as sleeve gastrectomy. The bottom line is that pretty much all the same things can happen. Same bad things can happen. The numbers are just different, that's all. Which statistics work great for a population. If there's 1,000 people, maybe 1% of them get this. Unfortunately, statistics don't work well for an individual, meaning that no individual, you, get 1% of anything. You either got it or you didn't, which also means it's not impossible. It may be a little lower risk, but it's not impossible. So could someone die? You look at the literature, it's about 1 in 1,000. Could someone get a leak from the intestine? Well, we're not dividing the intestine, but we're working right on it, so it could happen. It's about 2 in 1,000. Wound infection, blood clots, nausea, vomiting, dehydration, a little bit lower risk because the surgery doesn't take as long. And a lot of risk with surgery is how long did it take? And I threw an extra one down at the bottom. We've had 2 patients that were convinced they could feel their band on the inside and it was driving them crazy, which was driving us crazy. Well, I'll say you don't feel the band on the inside. You feel what the band does, but you don't actually feel the band itself on the inside. But they were convinced they could feel their band on the inside, driving them crazy, and eventually it was, let's take your band off. And we did. Now, long term, now we get a completely different list because now we're talking about, could you get a problem with a mechanical device? And the answer is yes, you could. Okay. Could the band slip? So we place the band on the very top of the stomach. But what if it slides down the stomach? The stomach is a lot thicker below that band. And that thicker tissue would get wedged inside the band, completely block you up. If that happened, we'd have to take it back to the operating room, take the band off. Could that little stomach dilate up? All right, now a couple minutes ago, I just told you that over time, these little stomachs dilate up, right? Yeah, so what's the deal here? So yes, they dilate up, but if it dilates up too much, it's going to kink over the edge of the band. And if it kinks over the edge of the band, it's kind of like a kink in a hose. Nothing is going through there again. And we have to take you back to the operating room, take your band off. Or could that band actually erode into the stomach? Yes, it could. So we're going to place this band on the top of the stomach. Now we're going to manipulate it over time, tighten it down. Could it eventually erode into the stomach itself? If it did, absolutely has to come off. So when you take all comers, need for some type of revisional surgery, what we're seeing is that 25 to 30% of people with adjustable bands need revisional surgery. Now, Europe and Australia have had bands available for a good extra 10 years or so. And the literature coming out, the numbers coming out of Europe and Australia, that's 40 to 50% of people that have adjustable bands need revisional surgery. So I'm not a big fan of adjustable bands anymore, not because they can't work, which we're going to talk about the results here in just a minute, but because it's a mechanical device. And over time, we're just seeing more and more problems with mechanical devices. All right, so what do we actually see as weight loss with adjustable gastric bands? It's not as good. The average best weight loss we see with adjustable gastric bands is 45% of what you were overweight. So if you are 100 pounds overweight, average weight loss about 45 pounds. If you're 200 pounds overweight, the average weight loss about 90 pounds. Okay? So it's significantly less. And then long term, about 50% of people regain, with adjustable gastric bands, regain most of their weight back. Now, part of that may have been they may have had to have the band removed. Pretty much their weight's going right back where they started. But for other people, it just does not work well. Okay? So overall, this is my take on it. I've been doing this a long period of time. Overall, with adjustable gastric bands, the long-term mechanical device problems with relatively poor weight loss makes it difficult for me to recommend gastric banding to people. Okay? There are always exceptions to rules, but for most people, I don't think it's a great choice. All right, sleeve gastrectomy. Okay, third option here. Okay, sleeve gastrectomy. What we do here is remove the greater curve of the stomach, or what I call the stretchy part. I can use this. Hopefully you'll see this pointer here. The greater curve of the stomach is this part here that the arrow is going to, and it's a stretchy part. Because when you eat a large meal, if you could envision this stomach being back together, okay? When you eat a large meal, as you eat, the stomach fills and it stretches way out. Okay? That's how it holds so much. It doesn't stretch in length this way. It stretches way out this way. So we remove this stretchy part of the stomach. It leaves you then with this tubular stomach or sleeve. Now, sometimes when people hear the term sleeve gastrectomy, they mistakenly think that we're placing something around the stomach. We're not placing anything around the stomach. It's referred to as a sleeve gastrectomy because we're changing the shape, like a sleeve on a shirt is tubular shape. So we're making it into a tubular shape. It's not that we're placing something around it. Okay? But we remove that greater curve of the stomach. It'll be gone. Nothing is bypassed, so there's no malabsorption, so your anatomy stays normal. So if you're eating food, food's going to come down the swallowing tube into this tubular stomach now, but then empty into the small intestine just the way it always did before, get digested just the way it always did before. Nothing is bypassed. It's just a much smaller stomach. Now, if you're looking for a visual, the size of the stomach here is about the size and shape of a medium banana. Okay, but again, your anatomy stays normal. But the other thing that occurs when we remove this greater curve of the stomach, when it's taken out, it'll be gone completely out of your body. It's this part of the stomach that makes that hormone ghrelin. And ghrelin, again, is a hormone that makes you feel hungry. So we take that part of the stomach out, ghrelin levels go way down, which means hunger is much easier to control. Now, it does not mean that you won't get hungry. There are still good reasons to get hungry. Just that hunger is much easier to control then. If you, again, think about it, hunger is one of the downfalls of just about every weight loss plan in the world. So it's increasingly popular. It's the fastest growing option out there. It's literally close to 95% of what I do nowadays. The surgery itself typically doesn't take very long. It's generally done about 45 minutes or so. 95% of them we do as outpatients. So people come into the hospital, they have the surgery, spend the day at the hospital, go home at the end of the day. So it's actually pretty rare that someone needs to spend the night anymore. Full recovery is not quite as fast as those adjustable bands, but it's a lot faster than gastric bypasses. Most people are fairly comfortable driving at about 3 to 4 days after surgery, and generally by about 2 weeks, feeling like I can do most things. Okay? About a month, you can do anything you want to. So recovery tends to be very quick with sleeve gastrectomies. Now, what are the risks? Okay, so same type of risk here, the first 30 days. Now notice that first 30 days, again, we get the same list as on the other operations. It's just slightly different numbers. Now, in theory, the death rate and leak rate should be the same as gastric bypass. Now, we're not seeing that. And literally, it's kind of closer to death rate and leak rate, kind of about 1 in 1,000 for deaths, and leaks probably less than 0.5%. But still, in theory, it should be the same as gastric bypass because we're dividing that stomach there. Okay? Wound infection, generally it's a short operation, less risk. DVT, PE with those blood clots, less risk because it doesn't take as long. Nausea, vomiting, dehydration, generally tends to be less risk. Again, surgery doesn't take as long. So, but it's not impossible for any of those things. Same thing for any of these surgeries, first 30 days, very similar risk, it's just slightly different numbers. The one thing, or I shouldn't say one thing, one of the things I really like about this operation is we've gotten rid of a lot of long-term risk. Okay? Long-term, you've got a normal anatomy. You've got normal anatomy, so once you're healed, you're healed. Okay? The thing we have to keep in mind is that stenosis. Okay? Stenosis, again, means narrowing. So we made you this tubular stomach. You'll sometimes hear it called stricture. It means the same thing. Stenosis, stricture, narrowing, that's what it means. So it made you this tubular stomach. Anywhere along that tubular stomach, could it actually scar down and get too narrow? Well, if that happened, we'd have to see one of the gastroenterologists. They can take a look down there, they use a little balloon, they can stretch it back out. So it would be even rarer to need more surgery. Not impossible. Now, in theory, stenosis should be about 1%. I've done over 1,600 of these now. I've seen one. Okay? And hopefully won't see one tomorrow, but we see much lower than 1%. But again, not impossible. All right, so what about the weight loss then? Okay, we basically see the same weight loss as we did with gastric bypasses. Average best weight loss, 70% of what you were overweight. So if you're 100 pounds overweight, losing 70% is losing 70 pounds. If you're 200 pounds overweight, losing 7% is losing 140 pounds. Now that's average. Some people lose a lot more. Some people lose a lot less. Okay? Long term. But anyway, going back to that thought, is that is very good weight loss, keeping your anatomy normal. Long term, we do see about 10 to 20% can regain their weight back. So again, with any of these operations, you can regain your weight back. Okay? Now, one of the reasons you'd think, okay, and this made no sense to me when I first started doing sleeve gastrectomies, is that it's a it's a little bigger stomach than the gastric bypass, and nothing's bypassed. It's like, why should we see as similar results? It's because ghrelin levels go down. If you think about it, in the other operations, that part of the stomach is still there. Ghrelin levels we're finding actually may be going higher than normal with the other operations, adjustable bands and gastric bypasses, which potentially is an uncomfortable situation in that I can't eat much, but I'm hungry. We can control that somewhat with appetite suppressants, but not necessarily ideal. With sleeve gastrectomies, ghrelin levels go down, hunger is easier to control. So just looking at the big picture then, I think overall, for most people considering weight loss surgery, sleeve gastrectomy is probably a better option. Again, not right and wrong, doesn't, it's not written in stone or anything. These are just options, but I think for most people, sleeve gastrectomy is actually a better option. One of the reasons? Well, we keep anatomy normal. Having normal anatomy is a good thing. There's actually a lower risk with the procedure, fairly quick recovery. We see really good weight loss with it, which is obviously the point. And we get rid of a lot of those concerns about just having anatomic abnormalities, which can potentially cause problems down the road, from anatomical problems with just obstructions or nutritional abnormalities with the vitamin mineral problems. Again, those are forever things. There's no mechanical device, so you don't have to worry about any mechanical device causing a problem. And finally, and we often don't hear people talk about this, is you haven't burned a bridge, meaning that, say you don't get out of it what you want out of it. Well, obviously, we're looking at weight loss and improving health. But you haven't burned a bridge. Your anatomy is still normal. If your anatomy is still normal, literally, you could have any of the other operations still done. I mean, literally, you could have it re-sleeved. You could have a band placed on it. You could have it converted to a bypass. You could still have any other weight loss operation. So you haven't burned a bridge, which is much more difficult after any of the other operations. Makes it much more difficult to revise this if needed. Now, having said that, we haven't revised these things. We see really good results with it. All right, so what do we see compared to the national average? Obviously, we're doing this for weight loss. That's the point. And the point of weight loss really is to improve medical problems, improve your life. So it can be lifestyle things too, but also a lot of medical and health things. So we see better weight loss. Again, we're doing the same operations as everybody else in the world, but we see better weight loss. If we're seeing better weight loss, the question is why? What's the education and support? It's how do you get the most out of this? Very important part. Again, we have a full year program afterwards. But with that better weight loss, we also see better improvement in medical problems. So I've listed some of them out there. Common ones, DMs, diabetes mellitus. We see 78% versus 62%, which are national averages. Hypertension is blood pressure, 62.5% versus 46%, national averages. Lipid, which is cholesterol, we see 70% improvement versus 45%. Sleep apnea almost always gets better, but 69% versus 56%. And reflux problems. Sometimes people think that sleeve gastrectomy you shouldn't have that done if you have reflux. But we see reflux get much better, not worse. Not impossible for that to happen, but we see it much improved. We see almost 3/4 of people with reflux get much better versus 16%, the national averages. Again, it's not the operation, it's what do you do with the operation? All the right things. If you do the right things, we'll fix these medical problems very likely. So again, why is that? The education support, we do have a full year program afterwards. I know I started with this as well. And we refer to it as Weight Management University for Weight Loss Surgery. It includes all kinds of different things, which I've kind of listed a lot of them out there. But some of the bigs that are just the educational access, from one-on-one counseling, but also I do live webinars every single week, just like this webinar you're watching now, which this one's recorded, but we do live webinars every single week, which you can then be involved with from your phone or your computer at home, anywhere you are in the world. Literally, you can join a webinar, you got access to me to ask questions. How good does that get, So lots of different things, but it's the educational support side that helps you with it. We have personal trainers, there's classes, and all kinds of different things. All right, so what should I do? And what should I do? Everybody can watch this. Hopefully it's good information for you. What should you do? Well, really, you need to decide what's best for your unique situation. And there isn't a right and a wrong here. But what I would encourage you to do is give us a call, send us an email, set up your one-on-one consultation. Let's you and I sit down and go over your situation, because everybody's situation is different. And there are good reasons to do different things. Okay, so give us a call, again, 757-873-1880, or our email is success@cfws.com. So final thoughts here, no matter what, whether you have surgery or don't have surgery, controlling weight is extremely important. And the reason is, so many medical problems are directly related to weight. So if we control weight, we control all these other medical problems. And if we can control all these other medical problems, it gives you the best chance of living that long, healthy life. So again, give us a call, set up your one-on-one appointment. So if weight's contributing to your health problems, let us help you. Go to our website, pick up the phone. Either way, easy to get hold of us. Thank you all for listening, and I hope to see you very shortly there at the office.